It is my sincere pleasure to welcome you to today's webinar, The Ins and Outs of Getting an Accurate Epilepsy Diagnosis. My name is Eileen Penn-Miller, and I'm a parent of a son with a rare epilepsy and a fierce advocate for people touched by the epilepsies. We planned this event during the month of February with intention because, as you may or may not know, this past Monday on Valentine's Day, we celebrated International Epilepsy Day. And on the 28th of this month, February 28th, we're going to be celebrating Rare Disease Day, and there are many rare causes of epilepsy. We also recognize that February is Black History Month, and an inordinate number of Black Americans are diagnosed with the epilepsies. On a personal note, a dear friend's son was recently diagnosed with epilepsy, and it was a reminder that diagnosis is a marathon, not a sprint, and it becomes a partnership between the person diagnosed and their trusted practitioner. I'm delighted today to be joined by two extraordinary panelists. We have with us Dr. Corwin Williams, who is the director of the epilepsy program at Phoenix Children's Hospital. And as you will hear today, Dr. Williams has a very warm and humane approach to caring for his patients. And we're seeing some shout outs in the chat from folks that know that firsthand. I also am so pleased to introduce you to my dear friend and colleague, Issa DeWoody. She's a parent, an advocate, and co-founder and director of Ring 14 USA. I would also like to thank our sponsors who made today's programming possible, including Jazz Pharmaceuticals, UCB, Ultragenyx, and Ovid Therapeutics. So without further delay, we're going to just jump right into this conversation. And I'm going to ask Issa to kick us off because her family has been touched multiple times by epilepsy, and I'm hoping that she can share a little bit about her family's epilepsy diagnosis journeys.
Thank you, Eileen, and for that warm welcome, and thank you, Epilepsy Foundation, for the opportunity to share our story. Really appreciate that. I saw somebody from Texas. I want to do a shout out to Texas. But actually, my story begins in Indiana. So we were living in Lafayette, Indiana, when my third daughter was born. And when she was 3 months old, she had the most subtle little thing that happened. It was our first seizure, and truthfully, I didn't even know if I saw what I saw, except that I knew that something had happened. You know what I mean? Something was not quite right. And after it was over and I talked about it with my husband, I immediately called a good friend of mine who's a school nurse. And she was the first one who kind of introduced the word seizure into really my vocabulary, and the fact that this is very much a clinical diagnosis, but what I had described sounded like a very subtle seizure. And we had already made an appointment to see a neurologist to get this checked out when my daughter had her second seizure, which ended up clustering. And so it didn't stop. So there was no mistaking this one. It was in seizure, out of seizure, in seizure, out of seizure. And we had our first trip to the local ER, and they quickly said, this is beyond us and our capabilities. And we had a long ER drive to Riley's Children's Hospital in Indianapolis, which brings up a really crucial point in the diagnostic journey, is that we actually found ourselves at the appropriate level of care very quickly. So this children's hospital went through all kinds of normal tests that's going to happen when you start having seizures. They did the EEG, they did a CT scan, they did an MRI, they did a spinal tap to rule out, disease and stuff like that. And even without our knowing about this or advocating for this, they ended up doing a genetic test. And this was 16 years ago. And so what was standard at the time was a karyotype. And that's where you look at the chromosomes and look at their structure. And it was actually the perfect test to diagnose my daughter. She has what's called a ring chromosome, ring 14 chromosome. So she has a ring on the 14th chromosome, and super easy to diagnose if you take the right test. But we heard after that what many rare parents are going to hear. Here's your diagnosis. We really have no idea. We've never seen a patient with this before. And we're a big children's hospital that's seen a lot of patients. They sent us home with a couple of different papers to read, and we were on our way. So I guess saying that, I just want to make a couple of points. And one is that what started out looking very simple and not very frightening turned into something that was really serious. And seizures that started out looking very benign at the beginning turned into something that were really critical. So they passed from being what are called partial complex seizures, which cluster, so they went one right after another, into tonic-clonic seizures. So this is something that happens sometimes in epilepsy, where you have this progression of seizure type. And also that we just happen to get the right test at the right time. It's very different today, that the diagnostic journey that you might go on might look far different. And they kind of rank these tests based on what's called diagnostic yield. So what's going to catch the most amount of diagnosis with the test. And I would just encourage you that this is a process, and that if one test fails, then you push for another test. And maybe Dr. Williams will talk more about this, but common tests these days are screening with gene panels that wouldn't have caught my daughter's diagnosis. You might do a microarray, which will catch different things. But once again, for my daughter, it's the karyotype still today, even with all of this. So there are monogenic syndromes, there are structural chromosomal syndromes, there's injury, there are all kinds of things that lead into diagnosis. And then unfortunately, I have another story to tell, very different than my daughter's, that started out very young and affected her whole development. And that was when my older daughter, who was an adult at the time, about to graduate from college, had also a very subtle seizure. And honestly, she wouldn't have probably recognized what it was if her life hadn't revolved around epilepsy and seizures from a very young age. And so we began a very different journey as an adult, trying to figure out what caused that seizure. And it's different, the processes from children to adult. And so she's now been diagnosed with temporal lobe epilepsy, which is very common, and it's a common cause of seizures as adults. But unfortunately, there's often not a smoking gun that causes this. And because there's kind of a familiar thing that runs through my family, unfortunately, we searched. We had to really fight to get a genetic test in this case, to see if something might come up in a gene panel in this case. And there wasn't. And so now you're left with, well, what really causes this? And we still don't have a clear answer. I've heard it said that any brain under the right circumstances can seize. And sometimes as an adult, it's just injuries that happened that accumulate, polygenic risk scores that go up, or a concussion when she was playing, flag football and things like that. So you may not have the same answer, but it's really important to look for it, because it can affect your care and things like that. So kind of a double hit in our family, and two very different scenarios. And so anyway, I wear a couple of different lenses when I look at this, how it affects my family through the extreme complex care of my younger daughter, who will always be our baby and always be under our care, and the very different scenario when it affects a very bright, ambitious young person. Epilepsy has a different affect. And the answers are not always as easy to determine, well, what actually caused this. So I hope I haven't gone on too long.
I'm so grateful. I'm so happy for you to be here because I think as Issa's stories have done such a phenomenal job of showing is that epilepsy really is a spectrum disorder. It can happen at any time, whether you're a young child or into your adulthood or even as a senior. And there can be many causes. Some can be genetic, some we may not understand the cause for. And depending upon where you are in that diagnostic journey, and in fact where you get diagnosed, as part of your story really demonstrates, it can really lead to different outcomes. There's so much in what you shared to unpack, and just thank you for your grace and your candor and sharing that with us. I'm going to turn to Dr. Williams now, to help us really understand, I think, both the difference between seizures and epilepsy. And also, Issa did such a phenomenal job of introducing so many of these concepts of what somebody might experience when they're getting worked up for an epilepsy diagnosis. So I'm going to have him help us unpack that as well.
Thank you, Eileen. And first of all, I want to thank you. And I really love being on this panel with you and Issa. And I want to thank the Epilepsy Foundation for inviting me as well. Shout out to Arizona as well. I think Issa did talk about a lot of things, and it is a lot to unpack. But, I think when I talk to families, I really try to come back to some first principles, because it's so easy to overwhelm someone when, honestly, they fall headlong into the world of epilepsy. It's almost like Alice through the looking glass. And there's just so much to kind of take in. So, I think talking about seizure and epilepsy is a good starting point. And I will say that it's confusing. And I think in part because even many medical professionals, including neurologists, use these terms kind of interchangeably. I'm an epileptologist, so I'm a bit of a purist in this regard. But I like to think of a seizure as an event. Someone has a seizure. It is a defined event. Epilepsy is a condition, a disorder, a disease where someone has a recurring tendency to have seizures without provocation. It's kind of an important point that kind of gets back to your something Issa said. Anyone can have a seizure. You're right. If you're in a car accident, you hit your head and you have a seizure, I think we'd always say it was probably because you were in that car accident. But I think what they have up on the screen is really kind of that distinction. So there you can see a seizure is abnormal activity, firing activity in the moment, often causing some sort of clinical change. Whereas epilepsy is defined by conditions, and there you actually see the medical definition. So if you've had at least 2 unprovoked seizures, so didn't have meningitis, didn't have a stroke, didn't get hit in the head by a baseball bat, but no clear provocation, they're more than 24 hours apart, have at least 2, we call it epilepsy, period, end of story. And I think that's an important point to keep in mind, because I know a lot of people, when they have that evaluation, they'll come back and say, well, it turns out her EEG was normal, her MRI was normal. I don't understand. She doesn't have epilepsy then. It's like, well, no, your child does have epilepsy, or your family member does have epilepsy, even if those other studies come back normal. It's a clinical diagnosis. Now, there are a few other definitions that, if we have a little bit more time, we want to dig into that, we can. But I really like to stick to that first 2 unprovoked seizures occurring at least 24 hours apart, because for most people, they have had the 2 seizures to justify the diagnosis of epilepsy. And that does, at that point, unlock a whole new world of how do we further extend the diagnosis. So I think most people are probably familiar with the brainwave study, the electroencephalogram. It is recommended or it's a guideline that if you've had a diagnosis of epilepsy, you've had an unprovoked seizure, that you have that. Why are we doing that? Well, for people who only had 1 seizure, it helps us to establish a diagnosis of epilepsy. But for people who already have a diagnosis of epilepsy, it allows us to classify the epilepsy. Is this a focal epilepsy? Is this a generalized epilepsy? Does this fit into a particular epilepsy syndrome? Why is that important? Well, that has implications about which medications are appropriate or potentially not appropriate for your particular type of epilepsy. Now, something else that we often do is imaging. Now, not always. For some people who have defined genetic syndromes, there may not necessarily be a reason, or let's say an epilepsy syndrome, we don't often recommend obtaining imaging of the brain. Now, that can be a CAT scan, but really the preferred test is an MRI of the brain. Once again, I can't see epilepsy when I look at an MRI, but what I am looking for is any evidence of old injury, any sort of structural abnormality that could explain why someone is prone or to having seizures to have eventually a diagnosis of epilepsy. So I would consider that fairly standard for just about anyone with the diagnosis of epilepsy, with the caveat some people with some genetic epilepsy syndromes would not necessarily get imaging. Now, that may or may not be revealing as to why someone has epilepsy. One of the issues that we struggle with, honestly, is the technology. So let's say if we turn back the clock 30 years, 40 years, all we would have had is a CT, a CAT scan, which is fine. I mean, you can see brain tumors, you can see probably old strokes, but subtle anatomical abnormalities probably are going to get missed. In 2022, we certainly have better technology, but even still, there are limits to what technology can see. And sometimes when people have had, say, epilepsy surgery, we actually have tissue in hand, we find that there's some abnormalities that we can see under a microscope that we could not see with our MRI. So that's one reason why MRIs may not be revealing of a diagnosis. And like I said, that can be a whole discussion in and of itself, but technology gets better every year. We currently have in common use something we call a 3 Tesla MRI. There's 7 Teslas that exist, not in common usage, but maybe as they become more and more commonly used, we might find previously normal MRIs may have some subtle abnormalities. Once again, there are many other reasons why people may have epilepsy. We've talked a little bit about genetic testing. I see there's been some chats, and I think the Epilepsy Foundation has also shown, has included some websites where you can read a little bit more about what are some indications for genetic testing and what are the different types of genetic testing. Like I said, I want to make sure we have enough time for questions, so we can certainly delve into that a little bit more. But certainly, particularly in what I do as a child neurologist, children who have autism, intellectual disability, normal MRIs, those are certainly people for whom there are recommendations to obtain genetic testing to further investigate it. As Issa already alluded to, there are many different types, and sometimes a negative genetic test doesn't mean that genetic testing is not the right test, but sometimes you have to find the right test. I will share with you, not all doctors are the same. I'm not a geneticist, so I do some genetic testing, but many times I refer my patients on to see genetics to help further investigate causes of epilepsy. So sometimes that answer may not always come from a neurologist. Perhaps it might come from another specialist. So once again, that can be another long discussion about the role of genetic testing. But I think it's important to understand there's more than one genetic test. Not every genetic test is equivalent to the other. And as I think you also alluded to, some tests may be more helpful in giving you information than others. We can go deeper into this rabbit hole, but I hope that's kind of a quick overview about some of the thoughts that go into some of the testing. And I guess just as a tail end, Issa talked about spinal taps or lumbar punctures. Those are sometimes also useful tests, and they give you information that can't be gotten through other methods. So that sort of metabolic or genetic testing can also reveal diagnoses as well.
I want to pause here and just dig in a little bit. I think there
Sure,
are some
absolutely.
questions that it would be great to give a little color to. One of the questions, I'm going to direct this to Dr. Williams, is can the EEGs be interpreted differently by different doctors? And I want to thank the folks for asking these questions, because I do think, I'm a parent, Issa's a parent, although, we have spent a lot of time in and out of medical centers, and you become more knowledgeable over time. But I think anything that we can do to sort of make some of this seem less complicated, less overwhelming, that's what we're here to do today. So let's start with that question for Dr. Williams.
That's an excellent question. And the simple answer to that question is yes. And I will say that if you actually look at an EEG report, typically the result is written as impression, not fact, not Bible, impression. And so it really kind of depends on the experience and capabilities of the provider who's reviewing that study. And as you will find in many aspects of medicine, many different people with different levels of training might do that. So I'm a neurologist by training. After I completed my 5 years of pediatric neurology training, I then spent a year just studying EEG. depending on where you are, someone might review an EEG who's only had just the standard 3 or 4 to 5 years of neurology training and has not done specialized training in reviewing EEGs. Depending on the quality of the recording, that can also affect how an EEG is read. So there are different levels. I'll be honest, it's sometimes a little hard unless you ask direct questions. Have you had specialized training in reading EEGs? Are the technologists who are actually performing the study trained, certified EEG technologists? Or sometimes we find in some smaller hospitals, you might have someone who's doing EKGs, which are heart studies, or respiratory therapists who are doing this. And that really can impact how the quality of the report that you get. So yes, different physicians can take away different impressions from different studies. And sometimes, it's important that you go see someone who has specialized training to have some confidence in those results.
That is actually a perfect segue to the next question that I wanted to ask. And Isa, maybe you can address this. You alluded to it a little bit before. So you started off with your younger daughter in an emergency room, but you ended up at a higher level center. And that is one of the recommendations that at the Epilepsy Foundation we make on a regular basis, which is that, if you have a complex epilepsy, if you're trying to figure out the cause and you need higher level testing, that you ask for a referral to a specialty center. Can you comment? And then Dr. Williams, I'm going to have you comment on the same, but can you talk a little bit about, sort of the different places that people get diagnosed and the differences potentially in care and in access as well?
We all at some point probably end up in a local ER. So I think with the first set of seizures sometimes, and that may or may not be the best place for you to arrive, depending upon whether it's a rural setting or a city, or it just depends on the capabilities of that local ER. But inevitably, you're going to be referred to probably a neurologist. And so I'm going to kind of introduce the difference between the term epileptologist and neurologist. So neurologist is more generalist, and they can help with a broad range of different things. But if your child or the patient, if they fail 2 different medications, then that's kind of the definition of a drug-resistant epilepsy. And if that happens, then the advice is that you should be referred to probably what's called a level 3 epilepsy center. So in other words, your epilepsy is probably not going to be easy to treat. And so the percentages on if you fail the first drug, what's the percentage that the second drug will work? And then what's the percentage of the third drug? Once you get from second to third, that percentage goes way down. Not to say that there's not hope, but just that this is going to be more complicated. And so you should probably go from neurologist to epileptologist, somebody who really just specializes in epilepsy care, and get to one of those level 3, level 4 centers. And that those levels of the centers really just have to do with, what are the capabilities of that centers? Are they able to do the imaging that you might need? Are they equipped with, well, this isn't actually a qualification, but we're fighting for it to be. Do you have, the capability to see a geneticist at one of those centers? So that you can talk about the different kinds of care that might be available to you that might be more specialized. And then I have to say, if you can get that diagnosis, that there might be what are called specialized centers for your particular syndrome. And those can be so helpful. So I'm kind of jumping the gun, and I'm kind of getting into the things that a specialized, an underlying diagnosis that explains your epilepsy, how this diagnosis might really help you. Because a lot of the rare epilepsies spend a lot of time, a lot of energy and money in kind of developing developing these programs, these multidisciplinary clinics or specialized clinics, so that you get the best care, hopefully as quickly as you can. And that leads to also being able to help out with the community and being able to grow kind of what they know about that syndrome, and to speed, treatments along and things at that level. So get to the right level of care. If you fail 2 drugs, then you probably need to consider what kind of care are you getting. Get to the appropriate level, and hopefully that gets you to a diagnosis, and that may in turn get you to a specialized center with special resources that might help your child.
I think Isa outlined that beautifully. I think I know that if you've had 2 appropriate medications that have been taken to high doses and you're still having seizures, then the likelihood of seizure freedom with further medication trials is only 5%. There are other options, for instance, surgery for people who are appropriate surgical candidates. There are other devices. There are devices such as the vagus nerve stimulator, the responsive neurostimulator, even deep brain stimulator. And certain centers like the level 3, level 4 that might offer specialized dietary support, nutritional support, such as a ketogenic diet or modified Atkins. Probably offer a higher likelihood of seizure control or seizure freedom, and those need to be considered. We certainly can always continue with medicines, but there may be other options that are better suited for you, and sometimes you might not find that. So to that point, if you've had 2 medications and they have not been effective in controlling, and by controlling I mean stopping your seizures, then we certainly would recommend that you seek out an epilepsy center. Additionally, the American Academy of Neurology has guidelines that if it's been a year and you still have seizures, that you should seek out an epilepsy center. And sometimes it may just be optimization of the medications. Maybe that's enough to get you to seizure freedom. That someone who has more experience in managing epilepsy, an epileptologist, might just need to optimize what you're already doing. But you may not know if you don't seek that out. So yes, I certainly wouldn't just go year and year and year of seizures without seeking out help.
Can I add something to that?
Of course.
Yeah, I just think it has been beneficial for us with Marie to seek out somebody new to look at her every so often. So, something that I notice as a parent is some of these changes in her behaviors and everything, they happen so slowly that sometimes you don't even recognize this. And I think the same thing can be true in the medical field, is that they've seen your child and there's this getting used to that this is how it is. And sometimes a fresh perspective or new eyes, new questions open up things that you might not have been aware of. And I want to emphasize that this is not a check against parenting, not to recognize subtle changes. This is not a point to be made about a certain doctor. I'm just saying sometimes a fresh perspective is really helpful in kind of just making sure that you have the right plan, or just opening your eyes to different things that may be options to you.
I think what both of you are reflecting on, and what we sort of alluded to at the beginning, is that this is not necessarily a one and done. Maybe in some instances, you get a diagnosis, you get on medication, you have your annual appointments, and you sort of go about your life. But in other instances, technology advances, imaging advances, our understanding advances. Maybe, you go to a different place, as we've talked about, some of these higher level centers, and you get new information that you can assimilate into either your care or the care of your loved one. So, what I think one of the takeaways we hope will be from today is that you have an open mind. And also use your resources like the Epilepsy Foundation. We're trying to throw many links referring you to resources. A lot of this information is available on our website.
Yeah, and I think there's been a recognition in the past decade or so about the role of genetic testing and the role of genes in epilepsy. So as we talked about earlier, I think it's fairly obvious if someone's had a stroke and they develop epilepsy, that's probably the case. So for someone like that, I don't think there's much of a role for genetic testing. But I think particularly from my world of pediatric epilepsy, we start to realize that things like autism and intellectual disability, which are in and of themselves risk factors for epilepsy, and increase just having those diagnoses tells me you're at higher risk for epilepsy than the general population, particularly when there's not some other obvious structural abnormality, that there may be a more significant underlying genetic basis for that. And, to be frank, in some ways, it doesn't always change how we manage the epilepsy. But, there is some benefit in doing the genetic testing and obtaining a genetic diagnosis for some of the reasons that you outlined. One, if you have that, you don't necessarily need to pursue more testing. So in that sense, you can kind of put in a stop to further studies. Secondly, sometimes you can identify if there are other health conditions that need to be supervised, surveilled. Sometimes maybe there's an underlying heart condition that goes along with that genetic condition. So maybe you need to go see the heart doctor, the kidney doctor, the lung doctor. I think for families, it also gives them some sense of peace as to saying, okay, this is why this is happening, to put a name to it, even if it may be a bunch of letters, but still it's a name and it's an explanation. I think particularly when we talk about some of the rare disorders, it also may help you find community. So for instance, if we're talking about ring chromosomes or things like that, you may seek out that community. And I know for a lot of my patients with genetic epilepsies, they're very actively involved in those particular type of communities. So community, I think, is always kind of important in that regard. So I think those are just some of the reasons why genetic testing is helpful and important. But as we've also alluded to, not all genetic testing is the same. And sometimes even the most sophisticated genetic testing might completely miss a diagnosis. Some of the older testing might be more definitive, just like Issa was talking about. So I really think it takes some careful consideration and discussion about some of the benefits of it. And we haven't really talked about some of the risks, but here in my state, we are actually obligated under state law to discuss potential risk. And one of the risks that I often share with families is some people may be overwhelmed by genetic diagnosis. So before we go into that type of testing, we need to say, are you going to be okay with this if you get this? Are you going to feel that your life is foreordained and this is how life will go forward with you? Now, that's not really going to be the case, but if that's how you're going to respond to a genetic diagnosis, then maybe now's not the right time, or maybe we need to talk about some education before we do further genetic testing. So I think it's a nuanced discussion. I don't think you need it for everybody. And once again, if you've had continuing epilepsy, we haven't found a cause and we haven't gotten them under control, does that mean everyone needs to have genetic testing? I'm not sure that we do, but I think that's definitely a conversation to open with your provider.
Yeah. I truly appreciate that. And I think what you're giving us is, tools. And that's what we hope that folks on this call, whether you're the person living with epilepsy or you're a caregiver to somebody living with epilepsy, is to just be aware that we had fewer tools many years ago. Now we have more. There's an appropriate time and place. Not all tools are available at all centers. And so part of your role as an advocate, whether you're advocating for yourself or for a loved one, is to be aware of what are the tools at the place where you're receiving your diagnosis. Have you, exercised and accessed all the tools at your disposal? And if not, is there another place that you can be referred to where you can access more tools? Issa, and I've got a few more questions I want to get to today, but before we move on to our next question, any other thoughts just about the genetic testing or some of that discussion we were just having?
Well, I just wanted, Dr. Williams gave a very thoughtful answer to that, so I appreciate his answer. I just might add, from a patient advocacy perspective, is that the fact that getting a diagnosis may not change your care now, I would be hopeful and add that it may change your care later. And if you have that diagnosis, it gets you to appropriate care quicker. It allows you to be able to participate in things like natural history studies where you try to define what the syndrome is and what, what the next person can kind of expect, or what you might expect in that journey later on. And he is very right in that these types of things can be overwhelming at time. I want to be very frank. It was not an easy thing to hear with Marie, that there wasn't going to be a quick fix, and to have to swallow that kind of whole all at the beginning, and to know that this was going to have implications for the rest of her life. And I think there's different people who handle that in different ways. I'm a true geek, and so is my husband. And so knowledge, like whatever we can feed ourselves, like that gives us some kind of level of, it just kind of gives us this illusion that we might have a little bit more control, but it depends on the person as to how effective that is. Um, but if you're trying to make decisions on, are we going to have more children in our life, and are we going to face these decisions with, these challenges with other children, to hear that something is what's called a de novo mutation. In other words, you and your spouse, your partner, you did absolutely nothing wrong. There's nothing necessarily wrong in your genetics that you've passed on to your child. It's just one of those hiccups that happens early in development, versus the fact that, you know what, there is a potential problem in my genetic makeup. And so I need to be careful in how in my decisions on whether to reproduce or not. So that can either be a weight off your back, or it can be a consideration going forward. So those are important things that diagnosis gives you. And I'll also just really quickly stress that, like Eileen said, is that, this whole realm of genetic testing has really taken off in the last 20 years. I mean, it's just, so if you have a brother or sister who's older, who you never knew, what caused their problems, it may not change, but I might just push. There's a need to get older adults diagnosed as well, because they are the living natural histories of some of these syndromes. So there is, from a patient advocacy perspective, this idea that there might be benefit in pushing that, even with our adult population who might not have ever considered, whether or not that was relevant or not.
Yeah, one quick thing I do want to add, because this is something that wouldn't necessarily show up, I think, from your end as patients, but from our end we see a lot, is something called prior authorization. So when we talk about money, that always gets everyone's attention. And so I think one of the limits on getting genetic testing is the cost. And a lot of times what happens on the back end is that insurance companies may say, I'm not covering this particular test unless you have documentation to support it. So a lot of our medical literature is really driven around, what is the benefit? What is the utility of having the genetic testing? And so, as I had mentioned earlier, say, for instance, if you have autism, intellectual disability, and epilepsy, it's pretty easy, straightforward to get at least certain types of genetic testing. Other more expensive types, we may have a lot more difficulty obtaining that. So some of that depends on who your payer is. Some of it depends on your particular situation, how severe the epilepsy is, how poorly controlled it is. So I just want that to kind of add that to the conversation. But I mean, I think all the things that, Issa was saying are absolutely true, and there are certainly benefits. But I also don't want you to walk away with the idea that you can walk in and say, I want this genetic testing. And I mean, it might be ordered, it might not be covered. And so that sometimes can be quite expensive, and certainly something to keep in mind if you're going to be responsible for paying for it.
Yeah.
Absolutely. And I'll leave it to Eileen to put in the chats. There are a couple of free resources to help people get diagnosed outside of insurance. And so I won't spend my time, talking through those, but we'll let that be in a follow-up on a chat. But somebody has bumped up that question of MRI a couple of times. So I feel like it has to be.
Yes, I was going right there, and that'll give me a chance to look for it's behind the seizures as one of the resources for getting some free testing. And I just want to, before we are getting to that MRI question, I promise you, but before we go there, I just want to comment that, if you're on this webinar, you're interested in epilepsy, you are an advocate for yourself or for your loved one, and we need you in the trenches. We want to help change those policies. We have incredible practitioners like Dr. Williams and advocates like Isa really working out there to help change, what is reimbursed in epilepsy and how do we get the greatest, make care accessible. So we hope that each of you will consider what role you might play. And trust me, ask to get engaged and we'll offer many roles. Now with that, I do want to transition to that question, which is coming from one of our guests who wrote, "I'm still trying to find out see what your diagnosis is. You've had a CT scan, normal, routine EEG, normal, upcoming video EEG for 3 to 4 days. So not too sure if you should ask for that MRI." And I'm going to ask, we can't obviously offer medical advice, but generally speaking, when that scenario occurs, Dr. Williams, what would you advise?
I would certainly recommend an MRI, just because, as we talked a little bit about how technology improves over time, the MRI certainly gives us more information in general than a CT for most situations looking for subtle EEG changes. It gets to be a little bit more of a nuanced conversation as well. So it's not just getting the test, but where exactly is that test done? Does that hospital, that institute have a specialized epilepsy protocol? Because the type of images that are collected, how they're collected makes a difference. What is the strength of their magnet? The stronger the magnet, the more detail you're likely to see. And then, once again, something that it's not easy to always know who's looking at it. So just like there are specialized neurologists who specialize in epilepsy, there are radiologists who specialize just in the brain. They're called neuroradiologists. But depending on where you go, you might see someone who's looking at chest films and bone films and brain films. So they may not actually have quite the same training and expertise to kind of detect subtle abnormalities. So, for my patients who come from far away, I sometimes say, I'd like to get at least one good MRI here because I have pediatric neuroradiologists and all they do is look at brains. And I certainly would trust their opinion necessarily over, say, a community physician who doesn't have the same degree of training. So that might be something, if you have that option, to advocate for that to make sure you're getting the best possible chance, the best possible expertise for your case.
I'm going to plant the seed also. This is in direct follow-up to what Dr. Williams said. And actually, I had a phenomenal experience at Phoenix Children's with my son personally. Even though I'm based in Maryland, we went for a second opinion there. They have a specialty that related to a diagnosis my son had. But I do want to just plant that seed that many of our level 3 and 4 epilepsy centers have a process where, let's say that the center is in, I'm making this up, Chicago, and you're based in New Jersey, there is oftentimes a mechanism where you can get a second opinion, and telehealth has both positives and negatives in helping that to happen. So, it's very, it's determined state by state, but I just, again, want to make a plug that you may live in a community, you may be that perhaps is more rural or has fewer resources. Don't let that narrow your view of what is accessible to you. There may be epilepsy centers, and we put the link in the chat, where you can get access to that either within your state at a higher level center or in an adjacent state or beyond. And I know folks are asking questions, are there level 3, 4 centers in Boston and other places? And there are, and I'll try to look for the link and repost it again to make sure that you have easy access to that. But there's actually a tool where you can look up by zip code, by state, and you can see all the different epilepsy centers. And yes, to all the questions you're asking about Boston and Johns Hopkins, they do have terrific expertise. Somebody also asked that even if your seizures are controlled and you're on meds, how often should you have an EEG or a VEEG? Is that something that it's like a one and done early on, or something that you do on an annual basis?
I would say that this can be provider dependent. But me personally, if someone is seizure free, I don't repeat EEGs of any type, whether they're short or long. Now, there are going to be some exceptions to that. So let's say, for instance, someone's having very subtle seizures. If there's some concern that there are subtle seizures, then you might have an EEG. But if the clinical impression is that your seizures are fully controlled, then that's not something that I routinely do.
I might add that the EEG is the best AED that we've ever had. So my daughter has had thousands and thousands of seizures, my youngest one. We've never caught one on an EEG per se, but it still gives hints to other things in her diagnosis, like a slow background, history and things like that. So but they're helpful if you can actually catch that seizure on. It might lead to a focal point and things like that. So anyway.
But somebody asked the question about the difference between the different lengths in the EEG. And I was hoping, Dr. Williams, you could just comment on that as well as one of our other diagnostic tools.
Yeah, the EEG is kind of a complicated tool, and I find even sometimes even my neurology colleagues have kind of a elevated expectation of what the EEG can answer. So, I would just say this, speaking back from first principles, what can the EEG tell us? If someone's had a first-time unprovoked seizure, and the EEG, even a short one, can give you some idea about the likelihood of recurrence, that can suggest whether or not they have epilepsy or not, determine if they have epilepsy or not. It's also good to classify seizures, whether they're focal or generalized in nature, or sometimes to classify the epilepsy syndrome. A third reason why we might use an EEG is to really quantify the number of seizures someone has. Now, obviously, we don't leave people hooked up for a year or even a month, but say, for instance, is someone having seizures 5 times a day or not, then I can bring someone in for 24 or 48 hours and say, like, well, at least in these 2 days, I'm not seeing any seizures. Now, if you're having seizures once a month, I really can't say that you're seizure free. But if you're asking, is my child seizing every day? I can do a 24-hour or 6-hour EEG and say, well, at least in this period of time, there weren't any seizures. And then really the last reason why people would be referred to an epilepsy monitoring unit is for surgical planning. So, or pre-surgical planning. So, and that's an instance in which we really want to capture seizures. And so if you're on medicine, we often will take you off medicine or sleep deprive you or do whatever we can to try and provoke a seizure, because we really want to see what does your seizure look like on EEG. So I think with those kind of goals in mind, that's really what helps you determine whether or not you need a routine EEG or a longer EEG, and why you need a 24-hour EEG or whether or not you need a 5-day EEG. So it's really about what your question is. And so if you're saying, I'm well controlled and can I drive because I have, say, absent seizures, I might bring you in for 24 hours, because I think in 24 hours I would certainly have a good idea. If your question is, I'm going to have surgery and I need to know where seizures are coming from, then that may be a longer study.
Great. Thank you for that explanation. So I would be remiss not to end with what I think is some of the most important information that you get from your clinician during, hopefully, one of your earliest appointments. And what I'm referring to is, if you are diagnosed with epilepsy, make sure that you are asking for or you receive information about rescue medications, seizure action plans, and being aware of what a SUDEP diagnosis is or SUDEP is. And Isa, I'm going to have you and Dr. Williams both just make a few comments about those topics, because I think it's big part of the Epilepsy Foundation's mission to not only help you get to diagnosis, but make sure you're armed with the resources that you need to make sure that you're living as safely as possible with your diagnosis.
Sure, I'll kick it off and then I'll let Dr. Williams finish up. I guess the thing that I would like to stress is that, a seizure is a medical emergency, and we have to have a plan. And it's not enough. Your plan has to be known, because if you're the one who's having the seizure, or if it's your child who's having the seizure, what you have to make sure is that the people who are interacting with them know how to appropriately respond to that. So there's things like How long do you wait before an emergency medical, before, you intervene? But the most important thing is physician, make sure the person is on their side and things like that. So there are just some fundamental facts about how to deal with this seizure that everybody who's kind of in the orbit of your child or the person that you love, like they need to know how to respond appropriately. And that can all be laid out very clearly with the help of your neurologist, your seizure action plan. And listen, SUDEP, which stands for sudden unexplained death in epilepsy, it's not something, it's a hard topic, but it's a topic that we do need to have discussions about. We need to be aware of the risk. We need to be aware of the risk of noncompliance to staying on your epilepsy drugs and everything. So there's a certain feeling in the epilepsy world, heart attacks are known to be emergencies, but sometimes seizures are not given the same gravitas. And, we want people with epilepsy to live full lives and to be able to, just reach their full potential. But we want to do this with tools in our belt that help them do that with as much safety as possible. So we just you have to know the risk to be able to evaluate the risk, which is a very personal decision to be able to evaluate what kind of risk reward you're willing to do. But let's know the risk.
No, I completely agree with both of those. And I think forewarned is forearmed. So knowing some of those questions and things to ask will really put you on a good standing. I find that when I meet families for the first time with epilepsy, there's just so much to talk about. And, I think we've just scratched the surface here. One thing I think I want to emphasize, though, at least for my patients, but it's true for adults as well, is that we also know that not just the seizures, or epilepsy is not just seizures, but it's also a higher risk of mental health issues that need to be addressed. So high rates of anxiety, depression, even suicide in the epilepsy community. So that's something that also needs to be managed and discussed, not with your neurologist, your PCP, or find a mental health specialist. For my patients in pediatrics, learning is often a big issue. The same is going to be true for adults as well. And I think those are just as important, sometimes more important, with regards to quality of life in living with epilepsy. So I think starting those conversations as well. So I just included the Epilepsy in My Child toolkit from the Epilepsy Foundation, which is just wonderful. It's a good way to kind of get yourself introduced to that. But I would just say, with regards to the seizures, also make sure you know what type of seizure you have. A lot of people don't know that, and read up a little bit more about that and how that's classified, because that has some treatment implications as well. So like I said, I think that this last question could easily be an hour in and of itself, but I think that's kind of a good place to start.
I am so grateful that you mentioned the comorbidities, because we couldn't agree more that, in some instances, the seizures are just one of many symptoms that a person or a family is managing. And you alluded to many, everything from sleep to behavior to cognition to development to delays, language. I mean, there are so many, and so we don't in any way want to downplay really the many ways that epilepsy can impact on our families and individuals. We are almost out of time, so I'm going to just ask both of you to leave us with any final words in like a minute or less, and then I'm going to share some wrap up, and then we're going to end this really productive and I hope informative webinar. Isa, would you like to go first?
I guess I'd just like to say I wish everybody the best of luck in this diagnostic journey. I hope you get your answers, the answers to your questions. I hope you find that. I hope you find community through that, because this is a journey where you need a strong support system. And so find that community, whether it's online, whether it's in your neighborhood, whether it's through EF, or whether it's through the Rare Epilepsy Network, and being kind of, networked with a community that looks just like yours. You're going to need that. And there are people here that want to help provide that for you. So I wish you the best as you try to care for those that you love. Thanks.
I kind of want to take a little different tack and just say, physicians are humans. Not everyone's great, not everyone's knowledgeable, and even we all have our blind spots. So this is really a collaboration with you as a patient, a family member with your provider, and you need to feel comfortable in that. So I've been seeing, I guess, a few concerning texts in the chat. If you don't feel comfortable with your provider, I always encourage second opinions, even with my own patients. And if you don't feel comfortable, it's good to seek someone else out because, at the end of the day, you need to feel comfortable that this person is caring for you and is making progress. So just keep that in mind too. Don't suffer and don't feel like doctors know everything, so they must be right and I'm wrong.
Thank you both for ending where you did. I think you've shared some very sage advice with our panel and with our guests today. I want to thank everybody for attending. I first and foremost want to thank Dr. Williams and Isa for your candor, for your straight talk, for your knowledge and your experience, and for your sharing. Really appreciate having you today. I want to thank our sponsors, and Annika, who's behind the scenes, can throw up a slide. Again, thank you to Jazz Pharmaceuticals, UCB, Ultragenics, and Ovid Therapeutics. And then I just want to call your attention to some upcoming events. If you are not seizure first aid trained, we have many programs that will help you get that. We have a 30-minute program that's on demand. We also have a training program that is a little bit longer, but gives you a 2-year certification. So we hope if you are not, you will consider becoming so. And if you know people, nurses, teachers, educators, caregivers in your community, you will encourage them to do the same. And then we also have some exciting upcoming events, starting with Epicon, which is going to be a big celebration of people living with epilepsy in Nashville, one of my favorite places, May 13th to 15th. It's going to be information and community and connecting, and we hope you will consider joining us for that as well. Thank you again today for watching, and stay tuned for the rebroadcast of this available on YouTube the end of this month. Thank you.